prevent the baby from being able to access milk. And the paper is fascinating because she talks about, she can imagine how the first-time mother who's anxious and worried and the latch is uncomfortable is going to be more anxious and more worried, and the baby's going to suck harder, and there's going to be less milk, and you're getting into this vicious feed-forward loop where things are not going to go well. Now, when I give this talk to med students, they always say, can we give shots of oxytocin? And I say, how about we take mom's feet out of the ice water? Wouldn't that be a better solution? And that's what those of y'all who do clinical work do every single day. You sit down next to mom. She's worried. She's like, I don't know. I don't think I can do this. I don't know. And you reassure her and you chat with her. You make a joke. Mom laughs. And all of a sudden you hear the baby go, goo, 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 and like milk is spraying everywhere because you have taken her feet out of the ice water. And I think this is such a powerful message about the importance of that connection between people to facilitate their good health and certainly the clinical work that we all do at the bedside. So the second part of breastfeeding success is latch. And here I'm going to teach, I'm stealing everything from Boston people. Ann Merwoods and my colleague Bobby Phillip talks about the hand puppet for teaching latch. So again, if you don't have your cards with you, this is the boob and this is the baby's mouth. The baby has to open wide and take the nipple and much of the areola into their mouth and hit the hard and soft palate junction. So you can demonstrate all that just with your two hands. You can't hold the laser pointer at the same time, but you can do it pretty well. And clearly this kid is biting on the end of the nipple and is actually squeezing the milk duct so that the milk can't come out. So mom is suffering and baby's not getting fed, and that is no good. And I think it's important for moms to understand not only does it hurt when that happens, but actually baby's not getting fed, so it's not like she's taking one for the team. So she really needs to use that as a signal to readjust the position. And then lastly, moving milk. So the more milk that goes out, the more milk that gets made. And there's really fascinating work suggesting that when that alveolus gets full and distended, prolactin doesn't stimulate milk secretion anymore because the boob is full. And so it's important to keep that milk moving. So when we start to look at the 10 steps, they're directly supporting each of these pieces of physiology. So the earlier initiation and skin-to-skin is facilitating letdown. Rooming in and outpatient support is taking mom's feet out of the ice water. Avoiding supplements and pacifiers is helping baby learn to latch. And then feeding on demand and avoiding supplements and teaching milk expression is moving milk. So the things we're doing in Baby Friendly are about supporting this normal physiology and helping baby and mom to do well. And it may help when you're talking to clinical people who are like, what are all these steps anyway, to try to explain to them that this is about supporting the physiology. It's not just some list that people made up one day, just for the heck of it. So step 4, as all of you know, is helping initiate breastfeeding early. And I just want to share a couple of studies that have just so been powerful for me to appreciate. I mean, this is another picture from Ready, Set, Baby in their skin-to-skin section. So this was a study done in a Scandinavian country, and I always conflate which one. But anyway, Scandinavia, that videotaped mothers and babies with baby skin-to-skin after birth. And what's really interesting here is they found these kind of standard phases of skin-to-skin, and many of y'all have seen the videos of this. The actual latching doesn't actually happen on average until about 80 minutes. So if you put a baby skin-to-skin and you don't interrupt, the expectation is not that the kid will be latched at minute 4. It's that baby will spend that time exploring and sucking and moving around, and that's this sacred hour that we want to give moms and babies to interact with one another. And I think sometimes, though, well, if we need to breastfeed in the first hour, then if we do it in the first 3 minutes, we're winning, so let's stick that baby on the boob. And that's not actually the physiologic piece. And I think that if the expectation is mom and baby will have an hour of uninterrupted contact during which the baby will eventually latch, that's a lot more pleasant and also lets the baby do it. So mom doesn't think she needs an IBCLC to latch her baby. She just needs her baby to latch her baby. Importantly, all this rooting and hand stuff is doing stuff. They measured oxytocin levels while moms and babies were interacting. And what they found was this is the maternal oxytocin levels, and this is infant massage of the mother's breast. So when the baby's doing this thing, they're actually priming the pump. They're moving colostrum down to the nipple so that when they latch, they've got something to eat. They're calling in their order, basically. So when we short circuit that and just stick the baby on the boob, we're not actually helping things, and we're potentially doing harm. And that's important because we always feel like if quick is good, quicker is better. I was going to make a crude analogy, but I'm not going to. But we'll leave there. But we really want to just allow mother and baby to interact. And the Cochrane shows very clearly that skin-to-skin in randomized controlled trials markedly improves breastfeeding outcomes across the entire first year. And the bottom line is that mothers who held their baby skin to skin in randomized controlled trials breastfed 43 days longer than women who did not. Now, this is not the crunchy mom with the birth plan and the doula and the midwife and, coming in with skin to skin and the teen mom who thinks it's gross. This is randomized controlled trial where mother and baby are put together and we watch what happens. We also know that skin to skin is good for every baby's physiology. It's not just about the breastfeeding. And that we see differences in heart rate, respiratory rate, glucose, and resolution of base excess. So I was so thrilled when our neonatology nurses and physicians came and said, we want to put the babies at risk for hypoglycemia skin to skin in the OR at section because we don't want them to be hypoglycemic. So as a hypoglycemia prevention measure, can you please make sure that that happens? Well, that was awesome. Because when crazy breastfeeding lady comes and says like, oh, skin to skin in the OR is really great, you should do it. And people are like, oh, crazy breastfeeding lady. But when neonatologists come and say like, baby's blood sugars are too low unless they're skin to skin, that is powerful. And it's been really a force in driving change in our hospital. We also know that babies skin to skin are warmer than babies in the incubator. And this is the incubator. This isn't the French fry warmer. This is like the full-on incubator. And the babies who were skin to skin became normothermic faster. Important to look at the x-axis here. This is 600 minutes. So what I'll sometimes see people do is baby skin to skin for about 4 minutes. The nurse checks the temp and is like, it's not getting warm. It needs to go to the French fry warmer. It doesn't happen in 4 minutes. It happens over hours. And so skin to skin is not like a one and done. It is a sustained process. And I think that's important to set that expectation so people aren't saying, well, it hasn't changed yet, so what's wrong? So how's Oklahoma doing? This is the MPINC report. It's 2013, so you guys are doing better than this. But it's important to look at, initial skin-to-skin contact at least 30 minutes. 63% had the ideal response, and about 62 with C-section. So that's 2/3, which is great. Initial breastfeeding within an hour. I think this data was shown this morning, a little lower. And then routine procedures performed skin-to-skin is a whopping 51st out of 51. You can give eyes and thighs skin-to-skin, but someone needs to show that and do it and have someone watch and see the baby not explode or fall or like anything else bad happen. And so I think that's an area to work on. There's data that they cry less and their heart rate goes up less when they're skin to skin. So we're really talking about, I won't say anesthesia, but an analgesic, if you will, for baby to get that heel prick when they're skin to skin. I guess you could say if they're not skin to skin, we're torturing babies, which is maybe a little bit forceful, but I really think we need to argue for that. What's that message to mom? We're going to give your baby its first shot, but he's going to be calmer because you're holding him. That's like, wow, I can help my baby cope. That's a lesson in the first hour that's really powerful. So this is initial. The MPINC is simply 30 minutes within the first hour. It doesn't say anything about latching. It just says skin to skin. Being opportunity. I don't make the baby-friendly guidelines. I think the challenge is to go between making sure that there really is a breastfeeding opportunity, and if they don't actually get a feed, and you're like, oh, we put them there for 30 seconds, they had an opportunity, done, checkbox, that people won't do the right thing. But I think that the data would suggest that putting the baby skin to skin and not messing with them is actually the quality metric, not the outcome measure of baby latched. And I think it would be interesting to talk to Baby Friendly USA about, can we phrase that in a way that recognizes the physiology? I think in most cases, someone is making the baby latch immediately because that's what they feel like they're supposed to do. There's a picture of my second son latched within 5 minutes. I don't know if that was me being pushy or the nurses being pushy. I'm sure that wasn't his idea. But I was like, yes, before the 5-minute APGAR. And what was I doing? Anyway, all of his trauma probably starts from there. That wasn't the kid whose Valentines could not be found this morning, that there was like a whole text message fiasco, but we found them. Excuse me. So when we talk about rooming in, I showed you all this slide earlier of Noah and me trying to figure out how to talk to each other. We need to facilitate all of these pieces and encourage breastfeeding on demand. So at CGBI, we've developed some provider tear sheets that are also available free to use. You just need to tell us your email address so that we know who you are. And this is instructions on healthcare professionals on how to teach feeding cues. And there's some scripts to use. We've been using these in the Empower Baby Friendly initiative and also in an initiative in Forsyth County in Winston-Salem to help hospitals get their providers on board with doing these different interventions. And there's a JMP/CGBI Empower provider. I made a bit.ly so that you could write it down quickly, hopefully. These are Oklahoma resources, which are wonderful, that also talk about feeding cues. And I think this one is in your packet, the one on the left. Is the right in the packet? So these are both available from the breastfeeding resource page and are another really nice example of how to teach cues to families so that they can help to understand what to look for. And ideally, this is happening prenatally so that they're not like learning about cues for the first time, in the middle of the night after, 5 hours of pushing and 48 hours of PIT. So step 6 is give newborn infants no food or drink other than breast milk unless medically indicated. This is another picture from RSB, Ready, Set, Baby. And here, Oklahoma is really rocking it. I was so impressed that y'all have only 11.1% supplementation rate, which is a whole lot better than the rest of the country. This is the 2012 data that I got off the CDC website, so you guys are doing something awesome. And here, the quality sub-score, your scores are a little bit better on the IMPINC. It sounds like there's some glucose water still lurking out in a couple of hospitals. But 33, interesting that 11% versus only a third of hospitals said that supplemental feedings to breastfeeding infants are rare. So I'm not sure how that corresponds. But so the other piece of this is the bags. And I know there's an active Ban the Bags program in Oklahoma. I was part of, Ann and I together were part of Ban the Bags founding way back in the day when Mitt Romney prevented Ban the Bags from happening in Massachusetts. And if we go out for drinks, I can tell you more. But anyway, this is a study that was done in the year 2000 by Cindy Howard, randomizing moms at the first prenatal visits, this is an OB care, to a commercial infant feeding information pack or a non-commercial pack. And they looked at odds of quitting breastfeeding all the way out after delivery. And that prenatal exposure to formula marketing material markedly increased the rates of breastfeeding cessation among women who were kind of on the fence about how they were going to feed. So these marketing packs are incredibly effective. Like, there's a reason that they spend all this money making them and giving them to moms. And I was interested, this is a couple years ago from one of the formula company sites. And you can see they have all these things about getting started, breastfeeding guidance, pumping, and then who's the happiest baby on the screen? Look how happy that introducing bottle feeding baby is. Like, oh, you can breastfeed, but if you want a happy baby, you need to introduce a bottle, right? So it's not that subtle. And then, really obnoxiously, this is their transitioning from breast milk to formula, little schematic. And you'll note that breastfeeding are these sort of cool blue circles. And what's formula? Love! You can introduce more and more love to your baby so that by day 14, it's all love and none of that cold blue stuff. So I think when we look at the materials that formula companies put together, they are very carefully designed to look enough like they're about breastfeeding for people to be fooled into giving them to patients, but they are totally about selling formula. And the activity of formula reps is totally about selling formula. So this was a quote from a training manual for Ross that was cited in a court case in the 1990s. And this is what the training manual said to the sales reps. Never underestimate the importance of nurses. If they are sold and serviced properly, they can be strong allies. A nurse who supports Ross is like an extra salesperson. So that super nice formula rep, and I was talking at lunch about Larry, the formula rep, that when he retired, there was like a big party for him at Brigham and Women's where I trained. Like, Larry's leaving. I can't believe it. I miss Larry. Larry's so great. Larry sent me ready to feed formula for a whole year for my baby. But that wasn't marketing. They have been cultivating the healthcare system, and it's not just nurses. This quote was nurses, but it's doctors. And, I have a Ross bear I got given by my pediatrician when I took my first kid to his first baby check. I mean, there's this going on for a long time, and it's no accident that we feel like breast milk and formula should be offered as equal choices, because the formula industry has tried to convince us of that for a really, really long time. So it's critically important to keep all of that out of your hospital, out of your OB's offices, out of your pediatrician's offices. And I'm really pleased that ACOG now says officially not to do that. And the AAP is not quite as definitive, but they say it's a bad thing. They don't say officially not to do it. And if you go to their annual meeting, you will see a lot of formula swag, which is very nauseating, but that is beyond the scope of this presentation. So then the last piece is about fostering community after mom goes home. This is another picture from Sarah Dragman of an Oklahoma mom breastfeeding her baby at, that must be the zoo. Are there elephants in Oklahoma generally? Or okay, but not at the zoo, not just roaming about, right? Bison, but not elephants. Okay, I'm from the East Coast. I'm kind of clueless. So one of the key things here is about integrating care. And I alluded to this a little bit earlier. You know, the obstetrician is like, okay, so the mom is my patient. And you'll notice there's this little wedge cut out for the boob. And the pediatrician says, well, the baby is my patient and maybe kind of part of the boob, but really not my problem. And lactation consultants are traditionally trained and taught to focus on the orobubular interface, but they don't necessarily have mom's entire health history in front of them to help inform their care, or baby's entire health history. And so what you end up with is this compartmentalization of pieces of two people in a way that's really not productive. Family physicians and midwives are the exception. They're licensed and trained to take care of the whole package. And that's a real gift when families are able to get care in that context. But for many, many women in the United States, their provider and their baby's provider are in different offices, on different health systems, in different area codes, you know, with different EMRs, and there's no chance of any kind of coordinated care. So one of the real challenges is how do we, when we send mom out, provide some context to the pediatrician and the OB provider so that hopefully there's some coordination of care. So the next piece is about fostering that community, and I was hearing about the COBA baby-friendly work and how awesome that has been. I'm trying to think if I can tell, I can't tell your story as well as you did, but she was telling me this wonderful story about at their minority COBA site, there were 3 women who were there, and 2 women were breastfeeding, and the third woman was like, well, I'm exclusively pumping. And she was welcomed into the group, like, that's great, however you want to give breast milk, that's terrific. So mom's sitting there, and she's looking at the 2 women. Finally, she's like, I think I want to try. And lo and behold, in the course of that baby cafe, that baby was latched, and mom was like, I can do this. This is awesome. But it was that opportunity to see other moms who were in the same place and make that connection that allowed that woman to be able to breastfeed directly at breast. And not everyone wants to do that. But this is a mom who, I don't know the whole backstory, but had been pumping and bottle feeding because she thought she couldn't breastfeed at breast. And lo and behold, she actually could. So I think we cannot underestimate the importance of providing places where moms can gather and share ideas and share experiences, and then have a little help from a knowledgeable person, a peer counselor, a CLC, an IBCLC, to help get those problems troubleshot and get those moms to do well. So how's Oklahoma doing? Well, the score on this is a little bit hard. Staff provide appropriate discharge planning, which is referrals and other multimodal support. Only 24% of hospitals had the ideal response in 2013. I don't know what the CDC counts, like is giving them the milk hotline adequate discharge planning. It seems like that should be pretty straightforward since y'all have a beautiful handout and it is available to everyone. Yeah, so having a place to call and a place to go and a plan is really important. And then the discharge packs, it was 54% of hospitals were not giving out the discharge bags at that point, and I know y'all have had more hospitals get bag free, so hopefully where the rankings will go, I don't know, but the percentage will get better. So what I want to just close with is some of the data about how this care is so important to women's breastfeeding success. And this is data from the Infant Feeding Practices study. And they looked at self-report of 6 of the baby-friendly practices that you can actually ask a mom. So you can't ask a mom, does your hospital have a breastfeeding policy? Because it's sort of hard for her to necessarily know that. But of the 6 practices they could measure, they looked at how many a mom experienced. And then if she planned to breastfeed at least 2 months, was she breastfeeding at 6 weeks? So this was not even, this was short of her goal, but at least toward her goal. What they found was where there were 6 of 6 baby-friendly practices in a baby-friendly environment, 97% of women accomplished their goal. In a baby hostel setting where 0 steps were in place, only 70% of women accomplished their goal. Fully a third of women didn't meet their own goal, and they didn't experience the hospital practices that they needed to be successful. And I think that's a really powerful message to share with hospital leadership, to say this is about enabling women to meet their goals. And when we don't do this, we derail people. There's also really concerning work from the CDC looking at MPINC scores and the racial composition of catchment areas, showing that in communities with higher proportion minorities, they're less likely to be delivering baby-friendly maternity care. And I think that that's a critical issue when we talk about health disparities. If women of color are delivering in hospitals that are over here, women of color are going to be less likely to achieve their breastfeeding goals, and that's going to make the disparities worse. So it's particularly critical that we make sure everyone has access to this quality of care. So this was the MPINK summary, and many of you have probably seen this. You all did great on documentation of feeding decisions, and interestingly on availability of prenatal breastfeeding instruction, although lots of people have told me that availability maybe and delivery are not correlated. I'm not sure how to put that together. But then supplements, model breastfeeding policy elements were not widely implemented. That's going to change because y'all have an amazing model breastfeeding policy, right? Everyone's got it. Protection of patients from marketing, and then adequate assessment of staff competency. So making sure staff members are up to date on their skills and know what to do. So we come back to this concept that we need to line up all of these pieces so that mom's breastfeeding goals actually translate into her actual achieved breastfeeding success. And this is ultimately about systems of care and about generally social determinants of what folks are able to do. In another plug for breastfeeding and feminism, in the introduction of Beyond Health, Beyond Choice, it's written, current public health promotion of breastfeeding relies heavily on health messaging and individual behavior change. Women are told that breast is best, but too little serious attention is given to addressing the many social, economic, and political factors that combine to limit women's real choice to breastfeed beyond a few days or weeks. The result, women's, infants, and public health interests are undermined. So we really need to continue our work fighting for policy and advocacy that makes breastfeeding an actual choice for all women. Right now, it's a choice, but it's not a right. And a choice that is not also a right is not a choice, it's a privilege. And that, I feel, is where we are in the breastfeeding world. So this is the Carolina Global Breastfeeding Institute website that has the resources that I shared with y'all. National Women's Health Information Center, I'm sure y'all are familiar with. Infant Risk and LactMed are two great resources for meds. Infant Risk is Tom Hale's group. And there's some things that aren't in LactMed because they're so new, like some of the new drugs for arthritis, or for lupus, or for multiple sclerosis. And if you call Infant Risk Center, they will look stuff up and give you kind of a real-time consultation. That's also helpful for the mom who's on like 5 different psych meds, each of which are maybe okay, but you're like, God, that's a lot. And they can help you kind of think about that. And then UNC's mombaby.org, we have protocols for management of some clinical breastfeeding stuff that I love to share with folks. I also want to do a shout out for the Academy of Breastfeeding Medicine, notwithstanding the limitations of their substance use protocol that were shared this morning. I know, I'm just sensitive because I was on the, there's some really wonderful guidance for providers, and this you can direct your obstetricians, your family physicians, your pediatricians to evidence-based guidance on management of different breastfeeding issues. So breastfeeding is a public health issue. Your care directly affects a woman's breastfeeding success. And a single hand cannot nurse a child. So thank you so much. I'd love to take questions. Am I out of time? I didn't. Okay. Yes. Yeah, so the question is, mom bottle fed the last 2 kids. She tried to breastfeed. It was a fiasco. She's not interested in trying this time. I mean, I usually say, well, do you know why we recommend that moms breastfeed? And if she says, yes, I know there's a 2-fold risk of otitis media, 3-fold risk of diarrhea, 3.6-fold risk of lower respiratory tract infection, and I have a 1.6-fold risk of diabetes, but I don't care. I hated it. I'm not doing it. She's made an informed decision. If she says, well, the formula now is more like breast milk than ever, so I don't see why it matters, that's a different conversation. So I think it's important to kind of see where she is. And I'm very kind of like, I'm not here to talk you into something. I just want to make sure that you have information, and if you ran into trouble last time and it's something we could correct, might you be interested in giving it a go? And I think if she comes out feeling like she's been bludgeoned, that's not good for her, and it's not good for all of us, because then that's another, breastfeeding fascist story that gets out into the ether.
Alison?
Yeah.
I wanted you to say to all these good people, none of whom are obstetricians, give them 3 tips to go back to their hospitals now and spread this information, because their doctors aren't here, and that's probably the biggest single challenge that we have, is to convince OBs, sometimes PD. How can they do that?
So 3 tips to take back to your OB providers. So I would give them a copy of the committee opinion, since that's ACOG. And ACOG is actually sending out a packet to every member of ACOG that has the committee opinion. It has like patient frequently asked questions sheet, and it has sort of tips for talking to patients about breastfeeding in your practice that's going to go to every single obstetrician at the end of February. So they'll be getting something from ACOG. And you can say, hey, I heard ACOG is sending out some breastfeeding resources. You know, I just wanted to say I'd be happy to come talk to your group about, you know, how to use these in practice or that type of thing. I think I would say, gosh, you know, this OB says that LactMed's the best thing in the world. Do you have LactMed? Let me help you download it. Like, because that's one where people get caught up all the time, and that you can do that at the point of care. And then I think that, I mean, maybe the thing to say is, you know, gosh, we've been really working on how to support moms who want to breastfeed to be successful. And I wanted to know, is there anything that, you know, is there any way we could help your practice with that? Like, do your nurses get phone calls? Could we come talk to your nurses about triage? Like, bring it as a, gosh, we want to make this better, and we're wondering, like, what can I do to help you? As opposed to, hey, stupid person, like, you don't know squat, and I'm going to clarify, which none of you would do, I know. But I think that issue of doctors hate being ignorant, right? And so if the patient asks the question and a doctor doesn't know the answer, most doctors will make something up and then be sure not to talk about that topic again, because they don't like being ignorant. And so I think that working through that is really tricky, and you have to massage that ego and allow people to learn in a kind of gentle fashion. But I think if you can share stuff with people like, hey, this new committee opinion came out, is there, you know, would it be possible for me to come and talk with some of your staff? That would be one way to kind of get your foot in the door. And I think the skin-to-skin is the easiest thing for the OB to have control over, right? Because if you don't clamp the cord, they can't take the baby to the warmer. And if you box out, it's even harder. So you put the baby skin-to-skin, and you're like, I played basketball in high school. It has paid off. And to see the mom appreciate that and have the OB kind of push for that is pretty low-hanging fruit from the OB standpoint. And obviously, if the nurse is intent on removing the baby from mom, that doesn't work so well, but that's sort of like a straightforward thing. Or baby skin-to-skin in the OR. Patients love that, and if they get a letter from their patient saying, oh my God, thank you so much, that was the best thing ever, then that will positively reinforce. So I don't know if that's 3 things. That's 5.5 things. Yes?
We're very excited about it. Oh, gosh. So the biggest thing for us now is we're trying to really talk to the OBs and anesthesiologists about skin-to-skin in the OR. We have a female CRNA, and that's pretty much the only one out of the 9 physicians that really will let us do that right now. So I think half of our OBs would be on board, half of them are kind of on the fence, just the same as with Baby Friendly. But I was just curious, the hospitals that do that, I know for sure in Australia and some of the other countries do that. What tips do you have for us to try to talk them into this?
So the question is, how do we get anesthesiologists excited about skin-to-skin in the OR? So part of it is to sort of try it. So a scheduled case in a skinny woman with no medical problems, you know, with a term baby that, you know, nothing interesting is going to happen that from a medical standpoint. And ideally a mom who says, I want this, because if mom is like, ew, then that's not going to work for you. And then have a staff person there. So one of the big concerns is, well, if the baby turns blue, who's going to know if the baby is on mom and under the drape? And I think that I can remember doing advocating for skin-to-skin, and I was working with one of our most midwife trapped in a doctor's body residents, and we had the lights low, and we had music playing, and the baby was skin-to-skin, and I was like, oh my God, it's dark. Is anyone going to be able to tell if the kid turns blue? And I, like, believe in this, right? So I was like, So we actually have our volunteer doulas come and facilitate skin-to-skin, and they're in charge of making sure the baby doesn't, like, crawl off or fall or whatever, so that the circulating nurse who feels like she has her checky box list doesn't have to deal with that, and the anesthesiologist who's busy monitoring mom's vitals doesn't feel like they have to deal with the baby. So I think having another person whose job it is to make sure the baby doesn't fall off the mom. So you've got a baby advocate. Yeah, so the question is the baby advocate, the baby nurse has this whole checky box list of stuff to do, and the skin to skin is like too much. So that was where we got this other person, this doula, who has no responsibility other than to make sure the kid doesn't fall off, which is probably overkill, but we need to make everyone feel safe about it. And, pilot it in the day in scheduled sections. If the CRNA has been okay with it and she's willing to have one of her colleagues hang out while it happens and see that nobody explodes, I think some of it is just seeing it and seeing that it doesn't go wildly awry. And then I think, once a couple people have done it and it goes okay, then it can start to grow. I think the challenge is saying tomorrow we're going to go to everyone skin to skin in the OR, and that people can't do that. That just drives people crazy. I do think that there's been all of the discussion and concern around skin to skin in general and the sudden life-threatening events, and I think that skin to skin in the OR is amazing, but someone needs to be paying attention to the baby, and someone needs to be paying attention to the baby. And same thing in the room, that just because the baby's skin to skin